there's obviously a human side to this, both from the patient, from the family experience, from the staff experience, but there's also a business side. So every Tuesday morning for the first probably 2 years, we started at 7 o'clock. We invited whoever wanted to come. They usually were the ones knocking on the door. They had 7 questions to answer. If you're worried about profitability, you're probably not going to be profitable. If you do the right things, it'll come.
Can you walk us through one specific design rule that you insisted upon, whether structural, mechanical, or planning related?
Sure. We're able to build 864 beds, 50 ORs, a new level 1 trauma center.
On this episode of the On Center podcast, we sit down with James Mladucky, the architect helping lead one of the most ambitious healthcare projects in the country, the new downtown Indianapolis campus for IU Health. We dive into the realities of healthcare architecture at massive scale, from balancing patient experience with operational complexity to designing hospitals flexible enough to adapt for decades to come. Jim shares insights from his career in healthcare design leadership, lessons learned from mega project governance, and what it really takes to deliver a project where the stakes are measured in human outcomes, not just square footage. This episode, of course, is brought to you by Map Solutions, providing high-accuracy LiDAR scanning, reality capture, and scan-to-BIM services for architects, engineers, and building owners. Jim, how you doing today?
I'm doing great. Thank you.
Wonderful.
Thank you for having me.
Thank you for coming on here and sharing your insights. I mean, projects like that. I grew up in Indianapolis, so Methodist has always been sort of an iconic feature driving downtown, especially down 65 or something like that. And IU Health has taken it over, and they're really massively expanding it. And I've been watching and the whole construction project from start to finish, watching the cranes go up and down, and it's been really amazing. So having the chance to talk to you about it is going to be a lot of fun, I think. Every architect has a story about how they found the profession, and often an equally interesting story about how they found their specialty. Healthcare architecture is one of those areas that demands a unique combination of technical rigor, empathy, and long-term thinking. Before we dive into the massive IU Health downtown campus project, I'd love to start with the personal side. What originally drew you to architecture, and what were the key experiences that eventually led you into healthcare design and leadership roles?
Sure. It's funny, but probably since about 2nd grade, I've always wanted to be an architect.
Second grade, okay.
Yeah. So, enjoyed drawing, enjoyed art, found that, I was good at math and science, so that's architecture is a nice combination of those things. There was a period of time when I thought maybe it was something different, but, I saw the light and came back to architecture, graduated, from, University of Wisconsin-Milwaukee, in 1982, and, uh, while I was in school, was working for, a curtain wall company in north central Wisconsin. Learned a lot about curtain wall testing, and have used that. Didn't think I necessarily would, but, it has come in handy, there's no question about it. And then we moved to, back to Milwaukee. My wife finished school where she was, where we were at the time. We came back to Milwaukee. I started in architecture and found my way into healthcare architecture almost immediately. It was more happenstance than it was purposeful. But, one of the things that UWM always focused on is the experience, the experience that architecture provides, and behavioral, relationships with space. So, healthcare seemed really to healthcare architecture enhances, or it can enhance those things. It really does affect outcomes, patient outcomes. It affects staff. And so the more I got into it, and then the nerd side of me, really enjoyed the multi layers of code that's required, and how they contradict one to the other, and how you navigate through all of that. So, I got into an architectural firm that was doing medical office buildings, graduated into a firm that did more hospital renovations, moved to Madison, Wisconsin, and worked for a firm there that also did a lot of pharmaceutical work and higher education work. So, continued to progress in my career and understanding of how space can affect outcomes and patient experience, always stayed in that healthcare niche. And they were partners with a company that did facility strategic planning for healthcare systems. And that that firm was fortunate enough to land the master planning for Massachusetts General Hospital at the time when they became partners. So they connected with Brigham and Women, Massachusetts General, to become partners now, and we did the master planning for that merger. That also included 5 other hospitals in that system in and around Boston, and almost immediately, one of the partners was able to also secure Lifespan in Rhode Island, which was another 5 or 6 hospital merger, and it was like one thing after the other. The firm was called Space Diagnostics. We were 8 people in Madison, Wisconsin, and I was traveling to the East Coast, quite a bit. Uh, One of the clients that I had, one of the partners also had in Milwaukee. It was, Columbia St. Mary's that merged together, and you were going to land on one campus, so then we started to do the master plan there. Um, was, anyway, the strategic planning side of it really came into light in understanding, in some ways, how the mathematics work in care and how to design around the staff needs and to maximize, a throughput, for different areas in the hospital. And so, there's obviously a human side to this, both from the patient, from the family experience, from the staff experience, but there's also a business side. And so, creating things that were efficient and effective, but yet beautiful,
Mhm.
was something that I really gravitated towards.
Sounds like it was a pretty logical progression, but I have to ask if you're willing to share, what was that one thing that almost took you away from architecture?
I thought maybe I wanted to be an electrical engineer.
Okay, gotcha. I've heard some interesting ones. Um, One person I interviewed, she was going to be a screenplay writer.
Okay,
Another one, was going to be a professional volleyball player. So, yeah, I'm just always curious
sure.
how those
Yeah,
things work out.
yeah.
On a project as large and complex as the new IU Health downtown campus,
Mhm.
the line between design leadership and project delivery leadership can get a little blurry. You are not only guiding architectural vision, but also helping manage an enormous delivery machine involving contractors, consultants, clinicians, administrators. As vice president of design and construction, how do you define that boundary between design leadership and project delivery leadership? And where do you personally step in versus just delegation?
Well, what one thing I found is that just pure delegation, you don't get the result you expect. So, you obviously, you have to trust the people, you have to have partners outside and inside the organization, and one of the things that Dennis Murphy, who is the CEO of IU Health, told me when I first came, he said, "Take 6 months to really understand this organization, who you can rely on, what experience we have here. Don't try to make an impact immediately. You'll make an impact, but you need that foundation first." And I think that was really excellent
Oh,
advice.
absolutely.
So, I took that time to get to know the community, to get to know the resources at IU Health, to better understand the university and that relationship that we had with, Indiana University, and Tom Morrison at the time, and Michael McRobbie, and it was Adam Tees. They became true partners, so that made that transition much easier. And then I got to know the community. You know, in some ways, when I first came, everybody wanted to know me. So instead of meeting with everybody or going out to lunch or having coffee or whatever you wanna it it became really obvious to me if I was going to get to know, the community, it wouldn't be over coffee. There has to be some of that, don't get me wrong.
Sure.
You need to build relationships, but I also wanted to make sure that my team was introduced to, and were able to share some of their insights as well. So every Tuesday morning for the first probably 2 years, we, started at 7 o'clock. We invited whoever wanted to come. They usually were the ones knocking on the door. They had 7 questions to answer, and, uh, and then they and the last one was, "Why do you wanna work for IU Health?" You know, uh, there are others that are much easier to work for. This is not gonna be it's rewarding, don't get me wrong, but we're demanding.
It's usually
So,
how it works, though,
yeah,
I find.
yeah. So, but that really has served me well and has allowed me to get much more involved in the community on many different levels. So, yeah,
Er,
hopefully
That's
I answered your
Yeah,
question.
I believe you did, and that whole story about when you started and the advice that you got is much different than um, the cliche manager who comes in and says, "Well, new manager, things are gonna change." I think that's excellent advice to get to know your surroundings, get to know your people before you start making changes. I think that's great advice. Um, IU Health has framed the new downtown campus as something bigger than simply replacing an existing hospital.
Absolutely.
It is described as a project intended to reshape the health trajectory of the region. That raises a fascinating question about how we judge success in healthcare design. 5 years after the hospital opens, what measurable outcomes would make you say that the design truly worked?
I think there's a couple of things. One is attracting the best possible clinicians from, the surrounding states, from the United States. When we start getting those chairs of departments, we're actually starting, chair of surgery, uh, the chair of cancer care came from out east. We've got, care radiation oncology now is, from, Johns Hopkins. So, it's starting because they see that vision. So, the, attract and retain is really important. And so this building, this campus is designed for it's more than a patient experience. It has to be, uh, a staff and clinician experience that is a positive one as well, and to create the synergy that we don't have today. Today, we have 2 campuses, University Hospital, Methodist Hospital, and they can be siloed. There won't be a silo now. You will be especially the way care is now being taught and how it's being delivered in team-based care, where it's not just the physician giving, care orders, but it's a team of 5 or 6 people, including the doctor, but the nurse, the pharmacist, the physical therapist, the occupational therapist, the radiology tech, it's, the researcher, who really come together and provide the best possible uh, care plan for that individual. And so when you hear best care designed for you, that's we're serious about that, and it really does make a difference, and that should change the trajectory of health in Indianapolis or in Indiana. Indiana right now is one of the least healthy states. And our goal and our stated mission is to make it one of the healthiest in the nation. This is part of that. It's not the only thing. There are way that's measured, and it is measured. The way that's measured is, uh, access to care is one, and that's where we come in, but how policy and government policy affects that, uh, the environment. So, uh, when people look and think about sustainability and what does that mean? Well, if you have clean air, clean water, if you're safe when you're doing your occupation, all of those things factor into that. So, we're part of that, and then the last piece is the behaviorals you bring, the behavioral how you feel about, uh, life in general. Do you have a will to live? Are you willing to give up smoking? Will you eat will you eat healthy foods? Those kinds of things are the hardest thing to move,
Mhm.
right? But if you can change any one of those 4 areas, you can change the trajectory of health in our area. And that's when we say it's bigger than, yes, the hospital is the catalyst, the campus, and bringing, uh, both hospitals together and bringing the School of Medicine to that campus and starting to centralize, uh, a health science campus is part of that, but how it then invigorates and changes the neighborhood and the community, and I think I've talked to you about this, there was a study, that if you go along the Monon Trail, life expectancy, and if you're in Carmel, I think it's 83 years old, that's your life expectancy. If you're just if you're on 21st Street in Capitol, it's 67.
That's a big difference.
Yes, it is. And that's access to care, that's social determinants of health. Can you what's the education like? What's the food? Is it a food desert? Do you have access to healthy food? Do you, are you able to secure a job? What can you do for your family? So, the health district is, part of this, and it's a partnership that we started with, citizens, with, the Children's Museum, with Ivy Tech, with, the city, and with the university. The 5 of us are as the anchor institutions to work with the community to make those changes in that area so that, in fact, there is workforce housing that's available. There is access to food that's, uh, that's better than, processed. We work our campus, is set up for, sustainability, and, we're going to be we're our project is, gonna be one of the first ones, I think, in Indiana on sites, so the site, sustainability goals that are set up for, U UB or, um, for, USGBC, and, so all of our projects are targeted for silver, but we're trending gold, and in fact, our central energy plant is close to platinum, which is phenomenal. So, but that there is a ripple effect when you do those kinds of things that it changes it cleans the air, we're gonna plant 1,000 trees. That's a huge deal in
Yeah.
the amount because there's almost no trees in that area today, right? Or very few.
You're gonna plant 1,000 on the campus?
Well, yes.
Oh, wow.
And, we're our vice president, of corporate real estate has a connection with a group that would literally be providing trees. So the trail that is now underway that links Fall Creek to the head end of the cultural trail, and it goes through our campus, and that was a missing link. It's, almost 2 miles worth of trail. That's underway right now, and this group is willing to plant even more trees along that trail to enhance, that experience for the community.
Oh, very cool. So it sounds like the measurable outcomes in 5 years that would tell you if it worked or not. You've already started to see the results of that in terms of like acquiring talent.
Yep, absolutely. What I would say though, this is the long run. This is a long view, right? So it to change the trajectory of health in that community, it's probably 30 years, but you got to start somewhere.
Do you expect IU Health to be up there in terms of recognizability with St. Jude's and John Hopkins and the big
That's
hospitals?
the goal.
That's the goal.
Absolutely. I mean,
Okay,
that should, if we do things right, that'll be the outcome, right?
very cool.
So it's I somewhere along the line, I remember, reading about profitability, and if you're worried about profitability, you're probably not gonna be profitable. If you do the right things, it'll come. And so in this case, if we do the right things, we will change the health of the community. We will be one of the healthiest states in the nation, and that's our commitment.
Very similar to my business philosophy, and that's serve others.
Exactly.
And then it comes absolutely. That's great. Um, the project originally planned for 672 beds,
Yeah, if you really wanna know, it was 575, but yeah,
575,
but it grew to 672,
and the 864.
yeah, and that came about because of COVID. So during the pandemic, especially Methodist Hospital w was the hospital for the state. So literally, you hear people talk about the sick that come to Methodist. They did. And, we used every single space we could. We had probably at the peak, a little over 1,000 patients that we were taking care of on that campus. And so initially when I first came in 2016, the thought was this is, one, we won't need as many inpatient beds as we once did. It's gonna be more outpatient focused or community-based focused. And, yes, there will always be a need for an academic medical center. We will always have, at least at that time, 500-ish beds,
Mhm.
and, but the pandemic made us realize that we're the only hospital in the state, we're the only academic health center in the state that could, in fact, take on that kind of role and effectively provide care for that many people in one spot. And that's what made us decide, we're not going to get smaller. We're going to right now, I might have the numbers wrong, but I'm pretty sure it's 856 beds that we have today between the 2 hospitals. So the 864 is slightly more than that, but, um
How did the design teams handle the change in
oh, it
footprint?
was fun.
Just fine?
Um, so, you ask a little bit about the difference, or maybe not, but I can tell you there is a difference between practicing architecture, healthcare architecture, and being part of the providers team.
Mhm.
And so when I was considering this, because I practiced healthcare architecture for about 25 years-ish, um, and, uh, and when I was thinking about going to Northwestern Memorial Healthcare at the time, I did a lot of work in different academic health centers, and so I called 5 of my clients and asked them, "Do you think this is a good fit for me?" And 4 of the 5 said yes. And then 1, Jose Fernandez from the University of Iowa, said, "Jim, don't do it." I'm like, "Why?" He said, "Architects are pleasers, and when you're in that position, you have to be the steward of the resource, and you're gonna have to say no,
Oh boy.
and architects don't wanna say no." And I'm thinking to myself, "Oh, c yeah, I can say no, it's not." I'm gonna say the first week, maybe 2, I learned what he meant when I took the job at Northwestern Memorial. And I had to deal with some, design that needed to be changed, and, talked with one of our leaders there who was the and this will start to get into, governance, but talked to one of the leaders there who was the executive sponsor of this project, and it was, expansion of beds on the downtown campus. And somewhere along the line, I was talking to her about the lighting that was in the corridor in an ICU area and how it would, it needed to be changed to match what the other aesthetic was in the connecting ICU versus, something different. And she said to me, "Well," she asked a few more questions, and she talked a little bit about the budget, and I said, "Oh, this is still within budget." And she looked at me and said, "I don't care if it's within budget because my job is to drive dollars out of this project because we have so many other needs in this organization that I need to bring this in below budget. So meeting budget isn't the goal."
Interesting. Wow, that was it that much of a culture shock from being an architect to that job as much as your friend
You
said it
know,
was?
I would say yes, because on the other side, I mean, I dealt with people in my position now, on many at many different organizations, but I never realized, uh, all of the things that are going on behind the scenes. As a designer, as an architect, it seemed like it was very clear. It was a very clear decision. Why is this? Why so much consternation? Not realizing the political things that are going on or the resource challenges that might be driving some other decisions or the recruitment that is going on. So there are so many things that you just don't see that are going on behind the scenes that and can't appreciate it until you experience it yourself.
Yeah, wow, and you've been in this position for how long now? This type of position?
I started at Northwestern in 2010.
Okay, so 16 years. Um,
More now.
16? 2010?
It's 2026, right?
Yeah,
Oh, you're right.
yeah.
I'm doing the math wrong.
That's all right. You've spoken about adaptability as a guiding principle for the campus. Hospitals rarely stay static for long, and the buildings that age best are the ones designed for change. Can you walk us through one specific design rule that you insisted upon, whether
Sure.
structural, mechanical, or planning related?
Sure. Yeah. So, in this case, uh, I before I went to Northwestern, I was with Canon Design. I was a principal there, and they had been working on modular design for a long time. And in fact, I think if you look up, oh, now I'm going to forget the name of it, but it's on the web. And when I was with Space Diagnostics on the strategy side, um, we talked and did a lot of facility assessment. So the hardest thing to change is the structure. In fact, rarely are you going to change the structure. The next hardest is the MEP systems, right? Uh, so understanding the module and then building from the smallest module, creating a framework that allows for the maximum flexibility. So, a 31-foot grid is what we went with, and that was something that, again, Canon Design had a 31-foot 6, but a little different. But it's based on you can do an OR in that grid, 1. You can do 2 patient rooms. You can put in 3 exam rooms. You can put in 2 imaging suites. You can put in, I think, 3, if I remember right, 3 wet bench research. You can do, so that it allows for this kind of flexibility within that grid, and it's based on a 12 by 10 module.
That makes sense. Okay.
So, uh, and, uh, and an 8-foot corridor.
Mm.
Um, and then the next thing is floor to floor height because of mechanical systems, because of technology and that kind of infrastructure that drives space above ceilings. And so the ideal is 18-foot floor to floor, depending on your structural system. And if you get into bed towers, we skinnied it down a little to 16 because there isn't as much infrastructure that's involved in an inpatient unit as there is, say, in an OR.
Makes sense.
So, so really the structural grid and knowing that that's wouldn't change, really is the module that we started with, and then, we built from there. The other thing that I was I was told very directly is, technology is something that continues to evolve, and by the time we build this and finish it and open it, likely whatever technology we were thinking of is obsolete.
Wow.
And, to be honest with you, there through this process, I think we're like 70 months into construction of the hospital, and we've had a couple of changes in technology.
Really?
RFID,
Mm.
real-time location find, that's changed. It's now wireless instead of hardwired. Uh, you know, we're we're integrating a camera system now, which we didn't have, that it will be in the patient room and in exam rooms. Now these are more or less heat sensing cameras, so you don't I can't recognize your face on this camera,
Privacy. Yeah.
but I know if you're in the room or if you've fallen or if you are in some other distress that the nurse call, you weren't able to connect with the nurse call, or if you're out of the exam room and there's no one in that exam room, it's ready to clean and get ready for the next patient. So it ties back to the scheduling system. That when we started construction, that wasn't contemplated. So the goal here was, I was told, "Give me the biggest pipe you can because I probably will need a bunch of gigabytes or terabytes or whatever, whatever the measurement is now, because technology is going to continue to evolve, and we will continue to utilize it, and, AI was we talked about it, but, it's progressed very rapidly, and so now that's gonna be integrated into, reading, medical images, so there will always be human interaction.
Well, and nobody was even talking about AI 70 months ago.
Right.
So interesting. Can you think of any design practices or principles at the beginning that allowed you to very smoothly ease into these new technologies that arrive as you've been building?
Well, I think that adaptation is the one that's probably the one that we've anchored on. Um, the other is in the this is going to be harder, to be honest with you, to meet. It's more about operations, but it's, transformation. So, how we transform care delivery in the future, not just in the hospital. And you know what? Again, the pandemic really accelerated that. Before the pandemic, virtual visits, I don't know, uh, it was maybe 2 or 3% was virtual visits. During the pandemic, it's probably spiked to 35 or 40. Now it's come down a little bit, but people still I mean, we got great, experience scores on virtual visits. People loved it. They didn't have to get in their car and go anywhere. They were able to interact with their caregiver, their physician. They got what they needed, and if you're relatively healthy, it works great. Now and the other piece of technology that continues to evolve is wearables. So, a friend of mine has, diabetes. He has a wearable on his shoulder. It's monitored back to his cardiologist who can go in and check his heart rate and his his sugar levels, and make sure that he's doing what he is supposed to be doing. Um, that's those kinds of things are gonna continue to evolve, and we're going to have to be able to adjust to that.
Sure.
And so that isn't always going to be at the hospital, but, and in fact, in some cases, it won't be, and that's why transforming that transformation of care is going to be more difficult, but it's happening. So best care in the best location possible. It's better to serve you closer to your home than it is to take you somewhere else and care for you. But how do you do that? You can do that virtually. When I was at Northwestern, the downtown campus was linked to our Lake Forest campus so that in the emergency department, if someone was having a stroke, they could actually bring in a camera and a neurologist could be with that patient and doing an exam with another caregiver in the room,
Mhm.
but they were able to assess that patient, while they were still in the downtown campus, frankly, likely even now at home, and so 24/7 isn't as difficult as it once was.
I'd be very interested over the next 5 years or so to see how AI gets brought into to healthcare. And I know right now there's probably it's probably sensitive with HIPAA and stuff like that because
It
a
is.
lot of them aren't set up for that yet.
Right.
But I think it will be, and it's gonna be very interesting to see where that goes. Amazon right now has an AI telehealth. Send it pictures and it'll I mean, that sounds a little too WebMD to me, but I'll be interested. What were you gonna say?
Well, yeah, it's going to continue to evolve, and we're right on the cusp, right? So who knows what's gonna happen in the future, but we're not going backwards.
Yeah, for sure. The campus includes major operational components like the South Support Building and the Central Utility Plant, which
Right.
quietly power the entire medical ecosystem behind the scenes. These systems support everything from automated logistics to infrastructure and redundancy. What design strategies did you use to ensure that this heavy operational backbone stays powerful and efficient without dominating the patient experience?
Well, do you think it dominates the patient experience?
I don't know. I haven't seen it.
As you drive by?
Um, I'm gonna be honest with you. I wouldn't know which building I'm looking at in
Okay,
those terms.
that's
So
fair.
maybe I should recognize it, or maybe it's just unrecognizable because you guys have done.
Well, yeah, so, one of the things, I'm not sure if this is where you're headed with this question, but, uh, one of the things that we wanted to do and we looked at is, does the central utility plant have is it a trigeneration? In other words, can it heat, cool, provide electricity for the entire campus? There are some regulations around in particular, electricity and, generating our own. Um, but we ended up with heat recovery chillers. We've looked at right now, the central utility plant is fossil fuel that's, uh, that's that's being used for generating that. However, in the future, we have set it up where we've planned for it to transition to all electric. The self-service building on the lower levels where our dock is, it's the docks, all logistics happen, below grade. It's 100,000 square feet below grade. Above grade is, all of the parking for the hospital, 2,600 spaces in that location connected by bridge. But we looked at and it is set up for solar arrays at the very top that would be enough to actually run that entire 100,000 square foot logistics hub. All of the hospital itself is set up to transition to solar in the future too. We looked at geothermal, and in the space, in fact, the space between the School of Medicine, the hospital, the current neuroscience Campbell to the north and I-65 to the south, that's about 10-ish acres, and so that could be a geothermal field in the future. So, right now with heat recovery chillers that we have and with, again, our cup is trending towards platinum, for USGBC, LEED. So it's pretty darn efficient right now, but we've thought about those things and incorporated what we could up front.
That's really impressive considering I can't even imagine how much electricity those buildings are gonna end up using. With all the equipment running, lights, computers, that's
My wife is very concerned about the data centers that are being built, right? So and I'm not arguing, there with that at all. Um, but yes, the hospital uses quite a bit of water just because of all of the toilets that we have.
sure.
But one of the things that we did work hard on is the chiller, that chilled water system. It's a closed loop system. We're using heat recovery chillers. We're doing everything that we can to minimize the amount of water that we use there, and also the amount of energy that we use. So yeah, we definitely took a long, hard look at what we could do, what made sense, and I think pushed it to make us a bit uncomfortable. So, which is a good spot.
Yeah, you said it's approaching platinum, which I think for a product that size is an achievement. That's
Yeah,
impressive. Um, Large public-facing projects often generate confusion around numbers, especially when budgets evolve over time
sure.
and different documents cite different figures. On a project of this scale, there is a big difference between conceptual budget, a forecast, and contracted costs. How do you balance transparency with the public while helping people understand what those numbers actually mean?
Yeah. Probably when I first came here, there was an announcement in the IBJ that we're gonna and build a $1 billion project downtown, right? So now, if you look at the most recent articles, or if you were to look at some of the our bond reporting, it's a $4.74 billion project now. Obviously, scope changed.
Mhm.
It got a lot bigger, but that is all in, and what I mean by that, it's all costs. So the cost of money, we IU Health is in a fortunate position where we have a strong ledger, strong bottom line, but we still went out to the bond market to at least bond part of this. Um, we So it includes the cost of money, it includes the design professionals, it includes all the planning up front, it includes construction, it includes equipment, it includes furniture, it includes commissioning, it includes building load, it includes training staff, it includes, all of those things that make up a total project budget. So, I think our CFO was extremely surprised when I told her that yeah, the cost of construction, now multiply it by about 1.6, and that's the total cost, and she
Oh, wow.
looked at me and said, "Are you crazy? It can't be." And she was right, it's 1.56, but, that's been consistent across multiple projects. So when I first came here, not only were we looking at the new hospital for downtown, but new hospital for Bloomington, and then renovation at Riley for moving the mother baby program there. And that grew to another, the cancer center at North, and the expansion out west, and the new hospital at Frankfurt, and through all of those things, that 1.56, 1.6 is consistent. And when I tell colleagues across the country who are building, I won't well, similar projects, they're shocked at what we're getting for the money that we're spending. They from their perspective in California, or in New York or in Texas, they can't believe that we're able to build 864 beds, 50 ORs, a new level 1 trauma center, all the clinics that we're doing, all of those things, this campus we're building, about 3.4, 3.5 million square feet new. And, so for that amount of money, they can't even come close to being able to build that in those states.
I'm gonna come out and
So, we're getting a bargain.
well,
People might not think that, but we are.
um, yeah, I mean, I really appreciate, but I have a hard time, conceptualizing those dollars on a project that size,
Right.
and the ability to organize where all those dollars go. Um,
Oh, I have a great team. I absolutely have a great team, and we did take probably some people think longer to plan than perhaps they would have,
sure.
but, because of that, we really anchored our, our budget, and we're able to and it's proved out, so, understanding where those costs are, where those hidden costs might be, uh, has really helped. And so we have a structure that we've developed at IU Health that really helps us predict and lay out a total project budget cost. And I mentioned some of those things
Mhm.
that are part of that people don't think about. When you're training staff, they're not providing care, but they're still getting paid. And so that cost actually has to be absorbed by the project.
Right.
So, so that's just one of the examples. You're right. It causes confusion when, it's announced that it's going to be $1 billion and then it grows. People are very quick to ask, how come this project is, I don't know. I have to do the math now, but construction cost, I think it's right around six or $700 a square foot. Is that right? Yeah. And maybe $1,000 a square foot. Um, but how can it be that much, right?
Sure.
But part of it is driven by codes. So a hospital has to have certain redundancies, has to be built to a certain standard for fire protection and prevention, has different, um, mechanical, electrical systems that are much higher end than because of air changes, because of filtration, because of, many different things. And so, it's legislated that way. So if we want to be reimbursed from Medicare, Medicaid, you have to meet NFPA 101 2012, not 2018 or 2022. And the only way that gets changed is literally by an act of Congress. So you have to get it through the House and the Senate and the president. That's why it only happens like every 10 or 15 years.
Hmm.
And so we're under an older code that's more restrictive. We're also under a state code that's IBC 2012, adopted in 2014 by the
Mhm.
state, which conflict one with the other in some cases. So the more stringent one has to be followed. So healthcare is the second highest regulated industry in the country. First is nuclear power.
Wow. I didn't know that, but healthcare being second makes sense. Nuclear power is number one. Cool. The phrase patient-centered design gets used a lot in healthcare architecture, but the real test is whether those ideas translate into physical spaces that genuinely reduce stress and improve clarity for patients and families. When you think about the new IU Health Hospital, which specific spatial experiences are you most determined to get right?
Well, we invested in getting the patient room right and the exam room right. So we brought in Clemson University, the School of Architecture has a research arm, and I'm personal friends really with David Allison, who leads that effort. And we spent a lot of time with about 200 of our clinicians and did several mock-ups on the room to make sure that it functioned, but then also it was patient and family friendly. We've engaged our patient family advisory committee. We have brought in and did additional research with, just different people from around the community. So we we paid attention to that, and we also looked at the research that's out there. There is research out there. I don't know if you're familiar with herd. It's,
I've heard of it.
yeah, so, there that's, it's interesting because physical space, it's hard to get that research documented because usually you can't replicate all of the different conditions. Things change.
Sure.
But we did our best to do that you know, with this, and we won a Touchstone Award from Center of Healthcare Design for that work. So, we are hoping to win another one for the exam room as well. So it's a combination of function and also, the experience and the design experience. I am very much a pattern language person, right? So Christopher Alexander and timeless way of building and those kinds of things. And so, the human experience is really close to me. And one of the things, or close to my heart, and one of the things that I really look at closely, uh, because we can we can believe we've designed something that's fabulous, magnificent, beautiful, but the real test is the experience the person remembers.
Hmm. Can you, off the top of your head, can you think of one feature of the patient room that is going to be recognizably different from past experience in a hospital?
Past experience, great question. Um,
I put you on the spot, so if you can't think.
no, 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 that's, so what I would say, uh, at least so there's, this I wouldn't say this is new, but there is a patient zone, a family zone, and a, uh, a caregiver zone in the room. But probably the thing that's most unique to this is just the footwall and the view out the windows. So we paid particular attention. I mean, the window that's into that patient room is, um, 7 feet wide and, 15 feet high. So the daylight that comes in,
Mhm.
the views that you have, especially to the east and to the west, um, well, they're beautiful views of the city, right? You're up 9 floors plus,
Oh, wow.
so, it's, and I would say the other thing that's unique is you walk off the elevators and you can see outside. So the person who is coming to visit their loved one, they immediately know where they are spatially
Mhm.
based on a view that they have to the west of, the city, the quad in front of the hospital, and that intuitively helps them navigate through the space. And then on the flip side, a lot of the caregivers, it's their nature not to leave a unit. They wanna be close to their patient. They feel if they go to, down to get food or to take a walk or whatever it might be on their break, they something will happen and they wish they would have been there. So, um So these waiting rooms, this that we have for those family members and the experience they have as they get off the elevators on the west side, we've replicated that on the east side, and we've created on the floor staff lounge, 2 of them between the towers. So 1 between each of the 3 towers. So the units, you can easily the caregiver can easily get off the unit, grab some respite, have a beautiful view, have a quiet spot, be off stage, regenerate, and come back, and not have to spend 10 minutes getting, or 15 in some cases, getting to the cafeteria.
Mm, that's fantastic. It's interesting that you mentioned the windows. It's a subtle, not so subtle, feature that I now that you mentioned it, I'd never thought about it before, but anytime I go to the hospital to visit somebody, I always go and look out the window. And, I think seeing a view of, like, the other building 15 feet away, has never been super fun, but,
Right.
that's really cool. Thanks for that. Mega projects often struggle under the weight of their own governance. Thousands of decisions need to be made quickly, yet healthcare projects must also incorporate feedback from clinicians who rely on the spaces every day. What kind of decision structure or cadence did you create to keep the project moving without losing the voices of the people who deliver the care?
Yeah, so, a couple of levels, right? So, I mentioned executive sponsors, so we do have an executive sponsor. Michelle Janney, or I'm sorry, Michelle Cesana is the president, and she's also a doctor of, the metro region, which includes the downtown hospital. And so she's the executive sponsor, um, and, uh, between and then we created a RACI, if you're familiar with, right? Who's responsible, who's accountable, who's gonna be informed, and and, who, who's gonna be, consulted. So so Michelle she is, she is that accountable person, so whatever happens, she's held accountable. I'm responsible for that project. So, I share that responsibility with some, but ultimately, I'm the one with Michelle, and before her, Dr. Nagy, Ryan Nagy, who went to the board and talked with them about this project. So, at the very top, there is a level um, of decision making that's pretty nimble. And what I would say is my counterpart on the operations. So I'm on the physical side of the house. The operations side of the house now is Erin Partee, and she is a nurse by training, has a lot of experience, most recently in Nashville at another academic health center. And so operational planning and physical planning come together in that responsibility and that co-lead, kind of a dyad approach, and then report to Michelle, who oversees the and approves everything. And then what we try to do is decisions are made at the lowest level possible. So as you go down the chart, there are there are obviously people who report to me who have different pieces and parts of the project, who are engaged, like, on the operational side, they're definitely engaged with all the caregivers. So, and we've done everything from QR codes, as they go through some of the mock-ups and are able to give feedback, to there are what we call super users, so who represent different areas of the hospital, and they're the ones who are coming forward and looking at designs, inputting what works today and what doesn't, and, working with our architects, engineers, contractors to develop and build this building so that it is the first of the new versus the last of the old. So,
From the outside, that seems like a complicated system.
it is.
Is it from the inside as well?
It is, but, I'm not saying it isn't, but, every academic medical center or academic institution in general has their layers
Sure.
uh, of politics and bureaucracy, but I think we've done a good job of streamlining it as much as we possibly can, but not lose the voice that's critical, and that's those who give the care.
Yeah. Saying it's complicated wasn't a criticism as much as just on a project that size, I don't see how it couldn't be complicated. Um, so, I mean, it works. So that's
It
good.
does. I mean, we've been able to be pretty nimble on making decisions quickly. So, but that's because, we did go through a lot of the planning efforts and
Mhm.
understanding who is responsible, who is accountable, who is consulted, and who will be informed.
Gotcha. Well, that's cool because most of the time with um, projects that size, companies that size, nimble's not an adjective I hear used a lot. Um, Earlier in your career, you worked on major healthcare projects in the Chicago region with Northwestern Memorial Healthcare. Moving from that environment to leading projects in Indiana must have revealed some interesting differences in context, priorities, and resources. Looking back, what is one design or leadership idea you carried with you from Northwestern unchanged and one that you deliberately left behind because Indiana's needs required a different approach?
Yeah, this one's tough because I'm not sure I left anything behind. And, I think, in fact, been able to leverage a lot of the experience that I had there, and at other academic medical centers when I was either a planner or an architect. Uh, I think that's actually served me well. What I would say is, Indiana is a unique place, and Hoosiers are very humble. They don't necessarily like to brag, right? So, and some of the things that this organization in Indiana provide, we should probably brag more. So, maybe I'll leave it at that.
I'll take that into consideration. Um, go ahead.
No, that's it.
Oh, that's all the questions I had. So, I think this was a great conversation. Thank you so much for taking your time,
Oh, it's
sharing your
my pleasure.
insights, sharing your experience, your knowledge, and hopefully the people listening will get something from it. So, thank you very much for your time.
Absolutely. I have a question.
Yes, sir.
What did you learn?
Oh dear.
What surprised you?
What surprised me is okay. So I'm going to be honest with you. I've been in a number of large organizations, the U.S. military for one, and I think that's where this thought process started, and that is the ability for large organizations like that to stay organized, to be able to get food where it needs to go, to be able to get logistics, planning, all this stuff, all these big pieces being put together to enable a whole to operate properly. And what surprised me is your ability to kind of make all that make sense in this particular context. Um, from the dollars to the team to the organization. So I think I learned a lot about that. I still don't know that I could do something like that. I can't. I'm a big picture person, but I can't break things apart and delegate like that. I think it's amazing. I think it's an amazing skill that you have. Um,
Oh, thank you.
so
But
yeah, I would say that's probably what surprised me the most is maybe beginning to understand how all that works due to your great explanation. Is that an okay answer?
absolutely. No, I
Okay,
appreciate it.
perfect.
So thank you.